I would like to invite Dr. Sujith Philip, who is the head of the department, the senior consultant of gastrosurgery, to go ahead and introduce the speaker and about today's topic. Over to you, sir.
Uh, Myself, Dr. Vivek Nath, I'm a consultant in surgical gastroenterology, Believers Medical College. So, good evening, everyone. I would like to welcome you all for another session of Health Horizons. So, our topic today is titled Cancer is a Word, Not a Sentence. It's a very powerful reminder that cancer, getting diagnosed as a cancer patient, particularly for colorectal cancer, it's not the end of the world, end of the road, but it's often a new beginning of resilience, care, and hope. So, without much delay, I would like to introduce the speaker, Dr. Sujith Philip. He's a senior consultant and head of the department of surgical gastroenterology. So, Dr. Sujith brings over a decade of his rich experience in diagnosis, surgical management, and holistic care in the field of colorectal cancer. He has been a mentor to many of us and continue to inspire us with his compassionate and evidence-based approach. So, without much ado, I would like to hand over the stage to Dr. Sujith Philip. Please take us through your talk and share your insights. Over to you, sir.
Thank you. Thank you, Dr. Vivek, and thank you to Dr. Sujith for the opportunity, and thanks to the hospital for the opportunity that has been given to highlight this very important topic. So we thought of naming this topic. Cancer is a word, not a sentence. Not a sentence means not a death sentence. We get a lot of patients in our OPD, and they respond in different ways when we tell them this diagnosis of cancer. But especially for this cancer of colon and rectal cancer, I just want to put forward the message that it is not a death sentence. So that has been our experience the past many years, and in our hospital, in our unit also. We've been having a lot of cases, and usually we end up having at least one or two surgeries of colorectal cancers every week. In fact, today also we had a similar case, and so we want to share what our experience we had in the hospital with colorectal cancer. So just want to title the talk, Cancer is a Word, Not a Death Sentence. So different cancers, like if you say the word human being, every human being behaves in different ways. Like some are very aggressive, some are very mild. The same way, colorectal cancer, though the word is cancer, it has a better prognosis, and because there's a lot of advance in the management of colorectal cancer. So the idea is the message is it's not a death sentence, just a word, and there is hope. The hope lives there. The key points would be early detection in colorectal cancer saves lives. And many of the modern, there are a lot of surgical options available for colorectal cancer, and they work. Along with other treatments, they work. It's not just a waste of time. And the survival rates are improving every year. If you look at the survival rates of some other cancers, let's say pancreatic cancer, there is not much survival increase in the survival rates over the last 50 years. But colorectal cancer, thankfully, is an exemption because survival rates are improving every year. So key points would be early detection does save life, modern surgery, and other treatments like chemotherapy, radiation, and immunotherapy, they work, and the survival rates are improving every year. Want to show you this surprising chart, surprising for those of you who are not in gastro. If you look at the survival rate of colorectal cancer, stage 1, it is 90%. Stage 2, it is 70%. Stage 3 is 50%, and stage 4 is 10%. Stage 4 is metastatic. You don't get such good survival rates in most cancers. It's in very few cancers would you get such a survival rate. So stage 1 would mean the tumor is stage 1 and 2 means the tumor is just limited to the bowel wall. Stage 3 means it is spread to the lymph nodes, and stage 4 means it is spread to distant organs. So even when it is stage 4, we have a 10% 5-year survival rate. So that's very big. And the incidence, one of the reasons for choosing the topic is that the incidence of colorectal cancer has been increasing. In fact, it's the increasing world over, increasing in India, increasing especially in Kerala. And it's the third most common cancer worldwide now, third most common. And the key thing, as I said, if you detect it earlier, it has a good survival rate. And in our unit, we done over today morning also we done over 500 cancers with the minimal morbidity and mortality, minimal mortality. And our focus has always been on quality of life and then long-term survival. As I said, the incidence of colorectal cancer is increasing. The reason for that would be westernization of our diet, less physical activity, obesity. So our lifestyle changes have contributed a lot to the increase of incidence of colorectal cancer. So how do you, what are the red flags when would one think of a patient having colorectal cancer? One which recent change in bowel habits. The patient is having normal bowel habits till now, and a few months having more constipation or having loose stools. So recent change in bowel habit. Next is bleeding per rectum. Others would be loss of weight, loss of appetite. These are important for any cancers. Bleeding per rectum, then a feeling of incomplete evacuation, and these anemia, unexplained anemia, these things would be telltale signs of a colon cancer. And herein we have the important thing of screening colonoscopy. Early detection that if it is stage 1, the patients have 90% survival. So the thing is that most of the colon cancers, so this is important, most of the colon cancers, they arise as a polyp, and then they would progress to a colorectal cancer. So if we can detect the cancer at the polyp stage, then we can avoid getting the cancer. This is unlike most other cancers. Yes. Most other cancers, we are not able to do that. So colorectal cancer is one of the few cancers where we can detect it early at the polyp stage, even before it becomes cancer, and then we can resect it endoscopically and thus prevent it from coming. So screening saves lives. When should we start screening? When should a person start having colonoscopy? The present Western guideline is any person over the age of 45 years should have a colonoscopy. Most Asia Pacific guidelines would say it's 50, but therein lies the importance of colonoscopy. Anybody over the age of 45 to 50 years should have a colonoscopy because screening saves lives. And staging, as I already mentioned, it's very easy to remember. Stage 1 would be tumor which is limited to the bowel wall. Stage 2, it is a deeper invasion of the bowel wall. Stage 3 is lymph node involvement, and stage 4 is metastatic disease. And as I already said, colorectal cancer is one of the few cancers where we have some success stories. So the last 50 years, the survival rates have been increased. So why have the survival rates been increasing? It is due to advance in surgery, radiotherapy, chemotherapy, and immunotherapy. The techniques in surgery that have contributed to an improved survival outcome. So say sometimes patients get confused when they come to the OPD and we tell them you need to undergo radiotherapy, then chemotherapy, then surgery. So after all this chemotherapy and radiotherapy, they're confused. Do we really need to undergo surgery? So the key aspect is that surgery is the primary curative treatment for colorectal cancer that needs to be removed. And the issue is that when we do surgery, there is a chance of recurrence. So all the other modalities are designed to prevent recurrences. So I would tell the patient like this: in surgery, we would remove the tumor that we see, and we also remove the places where the tumor is likely to be, like the lymph nodes. But there can be micrometastatic diseases elsewhere in the body. And it is to destroy that we give chemotherapy, or that we give chemotherapy. Now, though I mentioned colorectal cancer in a single word, they are different. Colon cancer and rectal cancer, they are treated differently. Rectal cancer is a slightly different ballgame in that it is in the rectum, as we know, is in the pelvis. The issue is that surgery in the pelvis is slightly more difficult compared to surgery in the abdomen. And also, the rectum is contained in an envelope of fat and fascia containing a lot of lymph nodes. So unless we remove the whole of that rectum along with the fat and fascia as a single lymph node, there is chance of recurrence. So because of that, because there is a real chance of recurrence, there are two things that are done. One, the surgery should be done in a particular way called TME, or total mesorectal excision. Two, to prevent a recurrence, we would give radiation to the pelvis before we do surgery. So rectal cancer, there is a role of radiation before surgery, then one would do surgery. Not in colon cancer. In colon cancer, there's no role of radiation. It's chemotherapy. Another fact that has changed, so I mentioned about the TME in colon, in rectal cancer. In the same way, in colon cancer also, we are supposed not just remove the tumor and the bowel wall, we had to remove the whole thing as a packet. It's called CME. So these are the two important progress that has been made in colorectal surgery, which has improved the survival, TME and CME. Not just cutting and remove the tumor, but removing it as a package along with this fascia and the lymph nodes without causing any rupture of the tumor. Another fact that has come up, which has led to improved outcomes in the form of less morbidity, is that laparoscopic surgery. Laparoscopic surgery has now changed the way in which we treat disease, colorectal cancer. This is because when we do laparoscopic surgery, it has the same results as open surgery. It is not inferior, and it causes less pain, better consequences, and more importantly, patients have faster recovery. So because of this, we can do more morbid patients. They are able to tolerate laparoscopic surgery. We will be able to do older and more morbid patients. And that's a kind of patient that we see also. Colorectal cancer, the median age, as time continues, as people live longer, they are prone more and more to more and more cancers. And so we get older and sicker patients with the colorectal cancer. And laparoscopic surgery has allowed us to operate on such patients. Other fact that has come up is that we do in a hospital is a thing called ERAS, enhanced recovery after surgery. What is ERAS? So when a patient comes to the hospital in our OPD for surgery, we want to see that the patient recovers in time, fast, and is discharged in time. This will lead to less morbidity. So for that, once the patient is enrolled, when the patient is posted for surgery, they're enrolled in a program called ERAS. Here the patient is taught physiotherapy, incentive spirometry. We try to build up the patient basically. So physiotherapy, incentive spirometry, and others would be, we try to improve them nutritionally. So we give them high protein diet. We had taught them exercises. And then we have set protocol, like we give them a high carbohydrate diet just before surgery. We avoid any sedatives. Then we start the patient on orals early. So there was a time when the colon surgery was done, we would keep them fasting for many days, but that is not the fact now. We try to start the patient on orals as early as feasible, and we would mobilize them as early as feasible. The normal idea a patient has now after surgeries, I had a surgery now, I need to sit down and rest. That's not right. We need to get them up early, mobilize them early, make them work fast early, and start them on diet early. This really helps to improve the outcomes. So that is ERAS. So due to these laparoscopic surgery, minimally surgery, and ERAS, we've been having low complication rates, and the patients rapidly return to normal life. Another key thing in treatment of colorectal cancer is that it is a multidisciplinary team. We take, if possible, we sit down together and we discuss with the medical oncologist, the radiologist, the pathologist, and then we discuss what would be the best management protocol for this patient. This is true especially for rectal cancer, when we need to decide what would be the best way in which we can face the treatment, whether it is radiation followed by chemotherapy, by surgery, or just radiation surgery. We also need to consider the health of the patient, the performance status of the patient. So it is important to have multidisciplinary team to take care of the patient and let it not be a one-man show. And we have a lot of patient stories in which real lives have been impacted by timely treatment. We have at least 6 patients over the last many years, stage 4 colon cancer patients who are still living even beyond 5 years. So real life impacted by timely treatment. We had a colorectal cancer conference the last December, and it was invited by one of our first patients, and he's now 63 and drives a lot, and he had stage 3 cancer and living a normal life now. So we have a lot of success stories. Another thing that is coming up is robotic surgery. As I said earlier, it is difficult to operate in the pelvis because the pelvis is very narrow. We won't get a good view. So robotic surgery helps us to do a pelvic surgery better. And we'll be having a robotic surgery department in a hospital in a few months, hopefully. And the other important thing that's happening is genetic and molecular profiling. I'll come into that. So finally, whom do we treat? We don't just treat the disease, we treat the patient. That means we have to consider the patient's performance status, who is there to take care at home, financial status, what is the type of cancer that is there, what is the genomic profile. So based on all these things, treatment needs to be personalized. It cannot be just like stage 3 cancer, I would treat like this. So it needs to be personalized, taking into factor all these multiple factors that are there in the patient. And so lately we've been doing a lot of molecular profiling, and we would, if there's a colorectal cancer patient, we would do things like molecular profiling, like mismatch, whether they have the thing called DMMR, deficient mismatch repair, or whether it's microsatellite inheritability, and whether these genes are there, KRAS, BRAF. So these all play an important role in deciding how the patient is going to respond to treatment and which all treatments we can give. So we can do this KRAF and BRAF and then decide how aggressive surgery also we can do. So if the patient has a BRAF, then we would not do surgery for some certain kinds of stages. Now, another interesting fact is that if a patient comes with a stage 4 cancer, like say stage 4 pancreatic cancer or any other disease, we would not even think of any curative treatment or any surgery. The scenario is different in colorectal surgery. Even if the patient comes with the stage 4 cancer, let's say liver metastasis, even multiple liver metastasis or lung metastasis, we can consider surgery. Now, before we consider surgery for such patient, we would do a molecular profiling also, genetic profiling also, and see whether they would respond well. So as I said, shown in this chart, patients who have KRAS or BRAF mutant, certain types of treatment are not effective, and we need to be careful about proceeding with surgery in such patients. And so they do affect the prognosis and therapy. And so we do this molecular profiling there, KRAS and BRAF, microsatellite inheritability and DMMR. And to give you this very famous article which came in the non-medical things also, is that if a patient with rectal cancer has deficient mismatch repair, it happens only in 5% cases, then you can even avoid surgery. You can just give immunotherapy and it just disappears. So immunotherapy does seem to be changing the scenario in treatment of colorectal cancer. So as I said, amazing facts about colorectal cancer, 5 year survival, much better than most other cancers. And that's why you're saying when a person has colorectal cancer, that word cancer is just a word. It is not that sentence. And the thousands of lives have been changed, and we've been able to give hope. So when a patient comes to the OPD with colorectal cancer, the first thing we give them is hope that this is not the end. Though this is cancer and all, yes, but this is treatable, and so don't lose hope. Together we can make a difference. So the key takeaways would be colorectal cancer is curable, is detected earlier. Surgery plays a central role, and hope and perseverance are essential. Because the treatment might take some time, especially for rectal cancer. It is going to take 6 to 8 months for the chemotherapy and radiotherapy and surgery and reverse stoma and all. But persevere, and you will live long, and you might end up having a good result. Yes. So we've been able to touch thousands of lives over the last 1 decade. And if there are any patients watching this, I would say don't lose hope. Together we can make a difference. Thank you.
Thank you, sir. That was a very enlightening session. So I would like to open the floor for any questions. If the audience want to ask any questions to Dr. Sujith, sir, the floor is open for you. If there is no questions, we will wind up this session. Thank you, sir, once again for enlightening with your wisdom, and thank you for being with us, sir. Thank you.